Thank you for the invitation to come out here. It really is a privilege to be here tonight, and I'm excited to be here and share with you a few thoughts. I did make the leap into academic medicine almost a year ago. I did, as Dr. Goldstein said, come from the Miami VA, and now I am full-time at the University of Michigan. So I consider myself an academic physician and practice evidence-based medicine, but I think you all will agree not all research is necessarily evidence-based. So while I applaud this guy's effort, my talks generally stay pretty evidence-based. So we're gonna go over some of the research, I think, that supports a lot of what has already been discussed this evening, and hopefully it'll be a nice summary for you. So first, we can play a little bit of diabetes and wound care by the numbers. About 7 or 8% of the US population, you probably realize, has diabetes. And 20% of all hospital admissions among people with diabetes are because of lower extremity complications. So it is a very significant component of what we see and what we do. Over the course of living with diabetes, about 1 in 4 people will ulcerate, and 1 in 4 people actually, because of issues with their feet, will not only be faced with a potentially life and limb-threatening condition, such as a foot ulceration or gangrene, but additionally they will receive their diagnosis of diabetes, a chronic medical condition for which we have no cure currently. So you can imagine the overwhelming state that most of our patients can be in, not only, again, being in that emergency room with a limb-threatening infection like the photograph that you see, but also being diagnosed with diabetes simultaneously. There are some statistics which really concern me, and I think will probably alarm you if you haven't seen them before. We are in a state of pandemic with diabetes. We know that 50% of Hispanic and African American children born since 2000 are likely to develop diabetes over the course of their lifetime. So I have 4 kids born since 2000. So if we think we have a problem now, my kids' generation, their neighbors, their coworkers, 1 in 2 of them are going to have diabetes. So we have a real problem on our hands. The other statistic is that 85% of lower extremity amputations are preceded by non-healing ulcers. So if we're going to make a difference and reduce amputation rates, the key is clearly to heal wounds. But oftentimes I think we're pretty good at healing wounds. The problem becomes on what I call graduation day, which is when that wound's healed and in fact keeping it healed. So again, to allude to the future, 57 million Americans currently have prediabetes, and the sobering statistic is that every 5 minutes in the United States, 2 people die from diabetes-related complications. However, 14 adults are diagnosed with diabetes. So again, we can see the disconnect in the number there. So those statistics lead to significant morbidity, mortality, and cost, and that's what I'll focus on tonight. So these are a lot of the patients that I see. The take-home message, again, from this clinical slide with lots of different wounds is that every wound has a different etiology. And of course, you have to understand why patients got wounded in order to understand how to prevent them from returning. So again, in my practice, it's not acceptable to understand what a patient has, but we understand why they got it and then how we're going to fix that problem in the short term in terms of wound healing, but also in the long term in the prevention strategy. So each of these patients I've treated, they all have a story, they all have families, they're somebody's favorite person in the world, so that's how I treat them. And I'll never go wrong with that because in reality they are someone's favorite person, whether they're somebody's spouse or parent or child, in fact. So the bottom line message with this is, again, each patient wants to live life despite having these wounds, and that's our challenge, to figure out how we can help them accomplish that. So why do patients get in trouble, or what's the etiology or pathogenesis of foot complications? So Larry Lavery did some work to decide or to determine in terms of evidence-based medicine, why do people get wounds? So the clear majority are what we'll call bumps in the night, right? That they end up getting out of bed in the evening, in the middle of the night, they go to the bathroom and they stub their toe. A lot of our patients, as many in the audience know, will have adequate circulation to perfuse a non-injured foot, but that supply is not enough to outweigh the demand when in fact there is an injury. So a lot of those minor traumas, cutaneous ulcers or bumps in the night, 73% of our wounds that we're dealing with are because of that. A lot of difficulties in wounds also are shoe related, over a third of them. Certainly if we have a correct foot exam and a patient puts on the wrong pair of shoes for even a very short period of time, then we can end up in trouble. And then there's other etiologies, of course. But the risk factors for developing these wounds are going to be neuropathy, peripheral vascular disease, deformity, trauma, duration of diabetes. We know the longer you live with diabetes, the more likely you are to develop neuropathy. And of course, the longer you are living with diabetes, the more chance that you will develop complications. And history, of course, repeats itself. So previous ulcerations will again forecast a shadow of coming events. So here's what I call the causal pathway. Neuropathy plus deformity is a setup for a wound. When you have a wound or an ulcer in the presence of neuropathy, that continues to perpetuate, and those can lead to infections. There's now an opening between the outside world and the inside world. Bugs and bacteria get in there. In the presence of infection and neuropathy, we see the common denominator here, then we can get bone infections. So it still amazes me, and it's a bit controversial, but in this modern day age of medicine, we do not have great antibiotics to penetrate bone. And so this, unfortunately, when you have bone infection, it leads to the antibiotic, which we as surgeons call a number 15 blade, and sets up patients for amputations, unfortunately. So Larry Lavery, again, kind of a pioneer in this field, studied folks to decide or to determine what were the risk factors associated with infection. Who was it that is going to develop infections? And he followed a cohort of over 1,600 patients in an outpatient tertiary care facility, which was a diabetes management program. So these people were under good surveillance, to use a term that's been used a lot tonight. He followed those patients over 2 years, and he asked the question, how many infections did these folks develop? And he saw about 9% infections over a 2-year period of time. About 2/3 of those infections could be managed outpatient. A third of them required inpatient management. And fairly consistent with the literature, there was about a 20% rate of osteomyelitis among those patients that get infected. So again, these are the patients that most likely will go on to amputation. But from the study, he came up with statistically significant risk factors for foot infections in people with diabetes. Those are wounds that probe to bone, and we know if you can take a sterile instrument, whether it be a cotton tip applicator or a curette, and you can visibly see or touch bone, we believe that the majority of those are infected with osteomyelitis. So wounds that probe to bone, a simple test that's done clinically and very kind of sensitive in our world to suspect osteomyelitis. Wound duration of greater than 30 days. I read a lot of clinical trials, and they have endpoints of 20 weeks, 24 weeks. You know, we're showing that patients are at risk for infection after 30 days. So there is kind of the fire that gets lit to heal these patients and heal them quickly. Recurrent foot wounds, again, I spoke about that earlier. Trauma, wound etiology, so those puncture wounds that we see in the emergency room, and then those patients with peripheral vascular disease. So these are known risk factors for developing infection. So as Dr. Goldstein alluded to, the clinician toolbox certainly has changed over time. I've been practicing for 18 years now, and 18 years ago, the toolbox didn't have a whole lot in it. There were definitely some tools, but now there's a lot of screwdrivers, there's a lot of hammers, and you have to know which one to pull out at what time. And I think we're fortunate to practice in a time when there are a lot of advances in diagnostic tools as well as treatment tools. It's my kind of cartoon, if you can appreciate, you know, the toolbox looks different today. So again, associated with a lot of mortality and morbidity with these patients. So speaking of that, I wanted to allude to some of the issues of major versus minor amputations. And sometimes we get a bad reputation that we don't heal wounds and that they go on to high-level amputations, and that we start off with a toe and then it ends with a foot and then it ends up in a high-level amputation. Well, there is definitely some advantage to saving toes instead of amputating feet, and certainly saving feet instead of amputating legs. I particularly don't like the terms major and minor amputation. I challenge you to find a patient of yours that has had a toe amputation that considers that minor. I really don't like that, but I think those terms are reserved for the literature and the research. But this is a great study where we looked at long-term mortality rates among patients who've had major versus minor amputations. And clearly the mortality is lower among patients who there is a more distal salvage procedure. There's also higher rehab potential. So we think that those patients can be more active and their quality of life can be better as well. So what you may not be able to see, and I apologize, my slides are probably small for you, but 70% of those patients who underwent a minor or a foot salvage procedure end up walking 1 kilometer. This study was done in Sweden. They end up walking 1 kilometer at their follow-up, as opposed to 19% of patients who've had a high-level amputation can walk that 1 kilometer at 1-year follow-up. 93% of patients with limb salvage or foot salvage procedures return to their own home, as opposed to 61% of patients with proximal amputations who end up institutionalized in nursing homes, and that drives up healthcare costs. And we think we're doing patients a favor by doing high-level amputations, thinking, oh, it'll get them back to activity quicker and sooner. The reality is that in this study, only 40% of patients regularly used a prosthesis. Many patients, because of issues of edema management, obesity, instability, neuropathy, all of those problems, they may never, in fact, walk again. They're in those scooters that we see in Walmart and in the malls and places like that. But ultimately, despite longer healing times, and we know that foot salvage oftentimes will take a much more effort to save that foot in terms of wound care, but we know that the patients overall will do better by having some sort of foot salvage. So here's another term which I came across in preparing for this talk, which I didn't like very much, which is called the Amputation Lottery. I don't know if you've heard this term, but the probability of major amputation actually depends on who you are and where you live. Believe it or not, that amputation rates, and it's been shown in the literature, vary by race, age, socioeconomic status, hospital volume, and geographic region. So again, I kind of got on a soapbox for a minute and said, you know, I want to treat everybody like they're my mom, and I like my mom. So, you know, I want to make sure that they're getting the best care. And I'm not sure that punching numbers or ICD-10 codes into a computer and the computer spitting out the procedure of choice is the way that we need to go. But Medicare and Medicaid patients are more likely than private pay patients to undergo high-level amputations, and we can't undermine the other costs associated with high-level amputations. Again, prostheses for life, making accommodations to folks' homes in terms of ramps and things like that, and then again, those long-term facility costs. So it's not as simple as saying, let's get this patient out of the hospital and do the high-level amputation because it's probably going to happen anyway. This article I came across I actually liked, which was new for me, and this is the patient's perspective. And again, that kind of mantra of you're going to have your toe amputated, then you're going to have your foot, then you're going to have your leg, and that has a bad reputation. Well, have we ever asked patients what they want or really involved them in that process of the decision making? So this was an interesting article that I came across at the University of Cincinnati. And the investigators, they actually wanted to find out the patient's perspective after having multiple procedures, and this is particularly in the vascular world. So these were patients who underwent multiple revascularization attempts prior to, unfortunately, ending up with a high-level amputation. These were not patients that were able to have foot salvage. After multiple revascularization procedures, they went on to high-level amputation anyway. And the investigators sent out a questionnaire a couple years later and said, would you do it again? Would you go through that process? And I think you'll be surprised. They studied these patients over a 6-year period of time at the University of Cincinnati. They had 78 patients that underwent high-level amputation after revascularization. They had a 59% patient survival rate. So again, fairly consistent with the literature. 13 patients were lost to follow-up, but ultimately they ended up with 33 patients that they could pose that question to, would you do it again? So there were, among those 33 patients, there were 142 revascularization procedures, which is an average of 4 per patient. And 94 of those procedures were open, 48 were percutaneous. So again, this is a complicated bunch of patients. I was surprised to see this. I don't know if you are. 85% of patients, of those patients who ended up with high-level amputation, said they would do everything exactly the same way to try and save their leg in a similar scenario, regardless of the number of procedures. So to me, that's very interesting information, and we can share that with our patients in terms of those patients that are maybe on the fence or say, I'm not sure, or what do you think? So in their cohort of patients, 54% of them actively used a prosthesis, and 91% of them resided at home. So I think they're doing something right over in Cincinnati. So we've talked a little bit about the morbidity. Let's move on to mortality. So this was alluded to earlier in the first talk. So this is a mammogram showing potential breast cancer on a mammogram on the far left. That's breast cancer under a microscope slide. And the clinical photograph, of course, this woman has undergone a mastectomy or a double mastectomy, it looks like to me, and the long road that's arduous ahead for her. There's certainly nothing to discount about this. But I would pose to you that this is, in fact, a more significant clinical scenario. A foot ulceration, the roadmap that our vascular surgeons use to determine how they can help or if they can help, and then, unfortunately, a woman who's undergone the similar marring and scarring of an amputation. So this was alluded to earlier, and these are the actual statistics that Dave Armstrong published. This shows mortality rates at 5 years for cancers as well as issues that you and I are dealing with on a daily basis. So prostate cancer has an 8% 5-year mortality. Breast cancer, again, we just mentioned 18% 5-year mortality. Hodgkin's lymphoma, 18%, but a neuropathic ulcer has a 45% mortality at 5 years. That's a big jump. Amputation, 47%, ischemic ulcer, 55%, peripheral arterial disease, 64% 5-year mortality. So I'm gonna ask you, we kind of simplify things again, but we talk about the rule of 50s. So if you take all those among those patients that we deal with, the rule of 50s is that 50% of amputations are major level, 50% of patients with one amputation will have a contralateral amputation within 3 years, and about 50% of patients with an amputation will experience mortality in 5 years. So I ask you, where's the pink ribbon for lower extremity revascularization and limb salvage? There's nothing sexy about saving legs or wounds. We don't get the NFL involved in what you and I do on a daily basis. Again, I'm certainly not saying anything against breast cancer. It's great campaigns and they've done a good job, but there's certainly social and media and Hollywood involvement in that cause with a much lower mortality rate than what you and I are dealing with on a daily basis. So we've talked about morbidity, we've talked about mortality, what about the cost? So when all else fails, we have to talk about the numbers and appease the bean counters and show them some of these statistics, which are really alarming. So more than 1 in 5 healthcare dollars is used to pay for costs associated with diabetes. Again, 8% of the US population, we're spending 20% of our healthcare dollars. So clearly that's not sustainable over time. We have to do something better about that. Also, interestingly, from the patient perspective, people with diabetes spend about 2.5 times more of their own dollars on medical costs compared to those without the disease. So these are the test strips. Y'all know how much CMS, if you have type 2 diabetes in the United States, how many test strips do they give you per month? Or how you want a glucometer at home? CMS, and interestingly, the American Diabetes Association, this is for type 2 diabetes, type 1 is a different story, but type 2 diabetes, they say if your hemoglobin A1C is relatively well controlled, you can check twice a week. That's what they'll reimburse you for test strips. You know how much test strips are? If you go to Walgreens, they're expensive. So it's, people are spending their own money, or they're not, and then they don't have the information, the knowledge, and the ability to move forward and to take better care of themselves. So we know that unfortunately, the people who are at risk for developing diabetes or living with diabetes are those who are financially challenged in many ways, the elderly and minority populations. So it's a double whammy that gets hit. So this is an interesting study from Australia. what they did, again, was look at patients that they treated for peripheral arterial disease with and without diabetes. And the question posed is it more expensive to treat peripheral arterial disease alone or peripheral arterial disease with diabetes? And you and I will intuitively say that it is clearly more expensive to treat patients with diabetes. But they proved it in evidence-based medicine. So inpatient cost of treating peripheral arterial disease with and without, it was an additional $1,912 per patient hospitalization compared to PAD alone. So over 18 months, this particular hospital spent an additional $528,000 on patients with diabetes and peripheral arterial disease as opposed to if they didn't have diabetes. So the reason is because the patients with diabetes stayed in the hospital an average of 15 days as opposed to 10 days without diabetes. So the additional inpatient management time costs more money. That was proven through this study as well, where they looked at lower extremity amputation rates versus wound salvage rates. And this is a question that we get posed all the time. You know, is it more cost effective to save a limb or to cut it off? And again, what they looked at was a prospective economic analysis here of 314 consecutively admitted diabetic patients with limb-threatening infections. And over the course of their time period, which was 18 months, the 40 patients died, which is a 13% mortality. 63% of their patients healed, and about a quarter of them ended up with amputations. But what ended up showing was that if you can heal an ulcer, it costs $8,500. If you did an amputation, it was almost $60,000. And this is pretty consistent with the literature. We say the average high-level amputation hospitalization is about $60,000. But they noticed that 82% of the spending is on inpatient management. So I say we send, you know, pennies in the outpatient arena. Dr. Howell mentioned some of the advances that we have at our disposal that we can do in clinic, and she did a great point in pointing that out, because if we can keep patients out of the hospital, some of these very expensively seeming modalities, $1,500 for a dermal substitute, that's actually cost savings, because if you admit the patient, you're going to spend dollars on the pennies that we're spending in the outpatient arena. So the multidisciplinary approach and evidence-based algorithms, I think, have been proven to be very cost-effective and, again, the right way to treat these patients. So we've shown in lots of studies, meta-analyses show that 80% amputation rates can be reduced by 80% when multidisciplinary approach is employed with our patients. So putting that patient in the middle, and then all of us with our own specialty, because I think, again, as Dr. Goldstein and I, you know, appreciated working together, I can't do everything. I don't know about revascularization or how to do it technically, but what he could do with that and what I could do with limb salvage and what our nutrition colleagues could add to the picture and, you know, the pedorthists afterwards, it's really is the team approach, and that's the right way to do things. And I'm going to give a plug to some of the other people among the team that I think are really important, and those a lot of times are mid-level providers. They spend more time with our patients oftentimes than we do as physicians. These are PAs and case managers, and they follow through on all the surveillance and making sure that things get done, and we really probably don't give those mid-level providers enough credit for what they're doing. Surveillance was mentioned, strong focus on prevention in multidisciplinary groups. We just know that that's the right thing to do. And again, when you have that team in place, consultations become very appropriate and smooth, and there was never a time when I received a consult, you know, that wasn't urgent. And I would never question whether or not it was important for me to visit with that patient that any of my colleagues had sent to me. So we also know that it's better to prevent problems than to cure them in terms of finances, because it's 5 to 30 times more expensive to cure problems than to prevent them. So podiatry and vascular surgery, I think, are natural allies, as this article showed, in the struggle against amputation, but we can't do it alone. Again, I alluded to, you know, and it's been spoken about this evening already, what vascular can do to restore circulation, and then in general what podiatry, or, you know, frankly, any foot and ankle orthopedist who has an interest in this area is fine by me. If you have an interest in it and you're good at it, that's okay. But in general, we see that podiatry and vascular tend to partner on these complicated patients. So podiatrists, just again, to give a plug to my own profession, again, I think we have a lot of time available to us, and there are many people who are very passionate about saving limbs. And this was a market scan data research that was published and showed that for every patient that is seen by a podiatrist prior to ulceration, we can save money. There are fewer hospitalizations, there are fewer infections, there are fewer amputations. So every dollar that's invested in podiatric care resulted in a $27 to $51 savings to the healthcare system in terms of prevention. So I think that's, probably very valuable and a take-home point. So I mentioned evidence-based algorithms, and again, I'm sure this is too small for you to see, but your centers, in theory, should be practicing evidence-based algorithms, and because they're inclusive and they dot the I's and they cross the T's. So for diabetic foot ulcers, we're going to assess the patient comprehensively. That foot is attached to a body, obviously. We're going to paramount and primarily look at the vascular supply. We're going to rule out infection, and then, again, appropriate referrals, and then follow that algorithmic approach to standards of care. When standard of care doesn't work, in 4 to 6 weeks, we have evidence-based products and modalities that we know will help the expeditious wound healing process. The same exists for venous leg ulcers. Again, your center should be practicing these, certainly in terms of ruling out arterial disease in combination with with venous disease, using compression, as was talked about. With venous leg ulcers, it's a little bit different. With DFUs, we talk about mortality. With VLUs, not too many legs are amputated because of venous leg ulcers, but venous leg ulcers are really significant decrease in quality of life for our patients. Those chronic draining wounds, malodorous wounds, we've had patients, become really depressed, clinically depressed because of that odor, and they lack socialization, they don't want to go out to eat, their spouse tells them to sleep in the guest room. I mean, we've heard it all because of those chronic draining wounds. So very significant decrease in quality of life. Pressure ulcers, again, there are evidence-based algorithms to follow with these patients because these are oftentimes avoidable, sometimes not. But certainly, oftentimes, our patients are most at risk are the cachectic patients, the nursing home patients, the frail and elderly. So there are ways to prevent these, as simple as I always think, there should be standing orders in intensive care units, admit to the ICU, place offloading boots, bilateral heels. It should be as standard as that. So pressure ulcers, certainly I don't think we want to neglect those as well. So kind of to put it all together, early recognition, I hope this kind of summarizes probably the 4 talks that you've heard tonight. Early recognition begins with patient and provider given exams. The CDC says that we're not doing that really well, about 60 to 70% of the time. People ask me who, is our common referral source. Anybody who removes the shoes and socks. In my clinic, we run a 2-for-1 special every day. I kind of say that because they come in for an ulcer on the left foot. They don't want to take their right shoe off, and you'd be surprised what you find. So early referral, it's obviously a whole lot easier to deal with problems on the front end than the back end in terms of complication prevention. And ultimately, if we're cost effective, if we're clinically effective, we'll be cost effective and reduce at least some of the burden that is facing us. Every patient scenario is unique. Every patient comes with their own set of comorbidities and psychosocial attributes. I think we use that term non-compliant a lot, but oftentimes it's a clinical depression, and I can't say that I wouldn't get depressed if I had a chronic draining wound that I had to go see the doctor 2 or 3 times a week sometimes. So again, I think we should be careful in labeling patients and really kind of figure out what their goal is in trying to heal them and what's stopping that from happening. So evidence-based treatments, I think, are the way to go. They are cost-effective. They show the lowest morbidity and mortality rates, and they hopefully will improve quality of life. And I think the mantra, which you all obviously subscribe to because you're here tonight, is that we should try at least to heal these wounds, but if we can't, then a toe before a foot before a leg, and a leg before a life. So during my time up here on this podium, 12 people have died from complications of diabetes, 60 people have undergone amputation, and 84 people have been newly diagnosed with diabetes. So there clearly is some work for all of us to do. I thank you for your attention. Happy to answer any questions.